So, first of all, let me thank Mindray for giving me this opportunity for this lecture. And I'm covering the topic of measurement uncertainty. Now, basically, why I chose this topic is when I am working in laboratory or when I am conducting many such trainings, the most important or the main question I get is it is very difficult or the topic is very complicated. So I thought I'll make it very short and I will make it very simple. So I wanted to start the session, and to make it very simple, I just wanted to take all of you to the 6th grade. So this is basically one diagram I have taken from the ICSE syllabus 6th grade textbook of physics, where you can see the measurement is done with the help of a measuring scale, and it has been given 3 positions: wrong position, correct position, and one more wrong position. So basically, this is called, in terms of physics, this is called error of parallax. So basically, this is a known source of error. So uncertainty is nothing but the known source of error. So this is a very simple concept. We have studied in our schools also. So why it has become so much complicated in our laboratories, that we have to understand. So first of all, coming to the definition, measurement uncertainty is a non-negative parameter characterizing the dispersion of the quantity values being attributed to a measurement based on the information used. So basically, it is a non-negative value. So any uncertainties or any variations in a values of your laboratory result will be called or will be termed as a measurement uncertainty. It represents the unexpected variability. It represents the unexpected variability in your laboratory results. So now here I have made one distinguish between what is error versus what is uncertainty. What is the difference between an error and what is the difference between uncertainty? So error is the difference between the measured value and the true value of the thing being measured. So this is basically a difference between the true value and the measured value, whereas uncertainty is a quantification of the doubt. So whenever there is a doubt in measurement, so uncertainty stands for that doubt which is used in the measurement of anything or any result. Then, as per the standard new ISO 15189:2022, as per the clause 7.3.4, evaluation of measurement uncertainty is a mandatory, and MU must be evaluated and reviewed periodically basis. For examinations with qualitative results, MU is an intermediate measurement steps or IQC results which produces. Quantitative data should also be considered for the key parts of the processes. So basically, it is not only for the quantitative results, but whenever you are generating any results where the ultimate output will be in terms of qualitative terminology, such as we are reporting as positive, negative, detected, non-detected. So basically, it is based on some of the cutoff values of maybe your absorptions or OD values. So while calculating the measurement uncertainty of these qualitative values, also you have to consider the intermediate step where the data is generated in the form of quantitative terms. So MU should be taken into consideration when performing verification and validation also. So MU is very important whenever you are considering the validation and verification of your measurement procedures. Now, what are the sources of these uncertainties? The sources of uncertainties come from equipment, object which is measured, methodologies which is used for measurement, environment, and personnel. So whoever are making the measurement. So these are the various sources of uncertainties in the measurement, and this combined together will be a combined uncertainty. So whenever you are calculating the uncertainty in the measurement procedure, you have to consider all the aspect of the testing. So why it is important? So here I have mentioned some points: clinical requirements for reliability, comparison of results with reference values. It can provide an insight as a technical step, and it can achieve as a standardized harmonized measurement results. So basically, considering and important, I will give you one simple example. So whenever we are performing a test examination of serum potassium in your laboratory, now the cutoff value for starting a treatment for hypokalemia is 2 millimole per liter. And whenever my results generated from the laboratory is 1 point, or maybe you can say it is 2.3. So my result is 2.3. The cutoff value for starting a treatment of hypokalemia by IV Kesol is 2.0. And the measurement uncertainty in my procedure is about 0.2 millimole. So when a value is generated 2.3, the clinician may ask a simple question, is it possible that this value can be up to 2 so that I can start the treatment? Then I can have an answer that my measurement uncertainty is 0.2, the value generated is 2.3. So the value can be as low as up to 2.1 or maybe as high as up to 2.5. So obviously it is above the cutoff value, so the clinician may not have to initiate the treatment. But when on subsequent analysis of other samples or the next sample, when the values come around 2.1, now the clinician himself has an answer that the uncertainty is 0.2. So that means the value can be as low as 1.9 and the value can be as high as 2.3. So the clinician may not come back to you for asking about the uncertainties or asking about the variation in the report. He himself can take the decisions and he can start the treatment depending upon the uncertainty which I have already communicated to the clinicians. So that is why it is very important for the clinical decision making. It may not be useful or it may not be important whenever we are doing some routine analysis or the values falls within the biological reference range, but when the values falls near the cutoff values or near the clinical decision limits, then obviously you have to consider the clinical measurement uncertainties. So what are the sources of measurement uncertainties? Here I have started from the pre-analytical or pre-measurement stage, that is differences in patient preparations, specimen collection technique, transport of samples, storage time and storage temperature of the samples, intra-individual variability such as pregnancy, fasting, non-fasting, drug use, diurnal, within individualized biological variations. So these are some of the sources of variation in the pre-examination stage. Then coming to the examination stage, you can see in this diagram there are various sources such as pipetting, which will affect the accuracy as well as precision. Then there are non-significant causes. Then causes related to the materials, which include calibrator, controls, samples, readings or observations I have made on the basis of blank count, linear range or the absolute count. Then the variation also depends upon the incubation period, length of the incubation, uniformity of the temperature during the incubations and temperature which is accurate, absolutely followed during the incubation phase. Coming to the reagent cause, batch number of the reagent, expiry date of the reagent, storage conditions of the reagent, stability of the reagent, robustness of the reagent. These are some of the factors which can also contribute to the uncertainty. And lastly is the operator, within operator and intra-operator variations or uncertainties. So these are some of the causes for uncertainties in the measurement phase. And then in the post-measurement phase, in the post-measurement phase, we have software where some algorithms are there. So there can be some variations in these algorithms. There can be variations due to reporting, number of significant changes. Some LIS systems may capture data up to 2 decimal points. Some LIS may capture data up to only 1 decimal point. So also it can contribute to the variabilities. So these are all the sources of variations. Now, how we can estimate this measurement uncertainties. So I am not going into the details of all those calculations, but here I am just describing two methodologies which are commonly used for estimating the measurement uncertainties. So there is type 1 evaluations, which is called bottom-up approach, where the uncertainty estimates using statistical data. You have to use number of statistical calculations. You have to use variation in each individual stage, and you have to calculate all those variations as a part of measurement uncertainty. The other approach is type B evaluations or top-down approach. Here, the uncertainty estimates from any other information. So in this top-down approach or in type B evaluations, you need not have to calculate number of calculations or you do not have to go through the tedious process of statistical analysis, but it is generally done by running your internal quality control on daily basis. With the help of precisions in those and accuracy of the calibrator material, you can calculate the measurement uncertainty. So instead of going for the complete statistical analysis by using type A evaluations, you can generally follow in our laboratory type B evaluations, which is called as a top-down approach, which is a very simple methodology for calculating the measurement uncertainty in your laboratory. I am not going to both the details, but for example, I have taken a detailed example or a flowchart for the type A because I have told this is a very complicated method and which is generally not followed in the laboratory and it is very difficult. So I am just mentioning what are the steps involved here in a type A evaluations. So it includes, first of all, you have to describe measurand, which is your measurand or interest. Then identify the sources of uncertainty from each component. Then you have to convert this uncertainties component to a standard deviations. Then you have to determine combined standard deviations. And finally, you have to report the measurement uncertainty of the procedure. So these are type A evaluations where you have to calculate number of statistical analysis to coming to at a conclusion of your measurement uncertainty. So coming to the next part of qualitative assays. Whenever there are qualitative assays, as I have mentioned, the report generated in terms of positive, negative, detected, not detected, then it is very difficult to calculate the measurement uncertainty. But in those some cases, it is basically like we are generating some intermediate step data, quantitative data. On the basis of those cutoff values, we are producing results which are classified as negative, positive, or detected, not detected. So on the basis of those intermediate steps, whatever cutoff values you are getting from your positive controls and negative controls, you can easily calculate the measurement uncertainty of a qualitative test where there are intermediate steps which are generating quantitative data. Now there are certain other qualitative tests where it is difficult to generate or where the intermediate step may not be generating any qualitative data. Now how to go for that? Again, we will see in the next slide. This is basically I have mentioned where it generates a quantitative output in the intermediate step. So again, it is a statement from ISO 15189. If the qualitative results of an examination results relies on a test which produces quantitative output data and is specified as positive or negative based on a threshold, mu in the output quantity shall be estimated using representative positive and negative samples. So whenever there are intermediate steps which are generating quantitative data, you can use the positive and negative controls to get those uncertainties of the intermediate step for calculating the measurement uncertainties of those tests. Now, there are certain tests where you will get a qualitative output and there will be no intermediate quantitative data also. Now, then how to calculate measurement uncertainty for those tests? So here, using false positives and false negative response rates of your laboratory and the prevalence of those diseases in your area, you have to calculate the measurement uncertainty of those qualitative tests. So this is a very simple formula. Maybe you can note it down because this formula is not given at all places to calculate the likelihood ratios of the qualitative test where you are generating a data on the whether you are generating the uncertainty without having an intermediate steps for any measurement uncertainty. So here you have to first of all calculate the positive likelihood ratio where you have to see true positive rate and false negative rate of your laboratory. Mind it, this is only for your laboratory, and you have to also calculate the negative likelihood ratio, which includes true negative rate divided by the false negative rate. So this is a very important formula when you calculate the measurement uncertainty for those tests where there are no intermediate step where a quantitative data is generated. So on the basis of this, you can calculate the mu in your qualitative results. Now, how to reduce those sources of measurement uncertainty? So once we have seen the measurement uncertainty in your qualitative test, quantitative test, then how to reduce these sources of variations? So first of all, you have to calibrate measuring instruments. So whatever instruments we are using in the laboratory, they should be appropriately calibrated. Make corrections to compensate for any other errors. Make your measurement traceable to national standards. Choose the best measurement instrument. Check measurement by repeating them. Check calculations and good measurement practices. So these are some of the sources or some of the areas where you can reduce the measurement uncertainty. Now when I am talking about measurement uncertainty and its implication of laboratory for the clinical use, many a times many people will ask whether it is important or whether it is necessary to mention this measurement uncertainty in your laboratory report. So as far as medical laboratories are concerned, it is absolutely not necessary to include measurement uncertainty in your laboratory result. Whereas for other laboratories, which includes food testing laboratories or plastic testing laboratories or some of the calibration laboratories, it is mandatory for them to include this measurement uncertainty in their report. But as far as medical laboratories are concerned, it is not mandatory to include this measurement uncertainty in your report. Rather than, you should not include it because it will create more confusions for the clinicians. So these are the some of the sources I have mentioned, or some of the measures I have mentioned to reduce the source of uncertainty in your equipment. So basically, with this, I am closing this short topic. If you have any doubts, because still we have a lot of time and I have covered this topic in a very short interval, please do not ask me how to calculate it. It will take for me 2 days to explain you how to calculate this measurement uncertainty.
Thank you, sir. Have any questions from any audience? Please go ahead.
Any doubts or any question?
It's a good presentation, sir, on behalf of uncertainty measurement. But I think, in lighter note, clinicians have a lot of uncertainty in our reports. Rather than we, a lot of efforts are making to compile the reports as far as best possible in our labs. But clinician still has a...
So basically, I will not call it as an uncertainties. I may call it as a mistrust. There can be certain areas where they do not trust your report. So we may not call it as an uncertainty. Uncertainty, I have already mentioned. Uncertainty is those sources of error where you know where the error can happen. So you know those sources of error. That is the uncertainty. Yeah. And what we are talking about, that is the mistrust.
How frequently do you estimate this measurement uncertainty? And when you do so, and you find a change in your measurement uncertainty, what do you do?
Now there are two things. How frequently we should do this measurement uncertainties. So monitoring is required, maybe on monthly basis. You need to calculate the measurement uncertainty on monthly basis. See, there are no specific frequencies defined. So it depends upon what good practices we have to follow in laboratory. We had one session in the morning where they have mentioned about the good laboratory practices. So as far as accreditation guidelines are there, or as far as any international guidelines are there, it is not mentioned any specific frequency. But as a good laboratory practice, we should monitor it on monthly basis. And if there is any change, as madam has asked, if there is any change in measurement uncertainty, what should be done? It should be recorded. As I have mentioned, it is not mandatory to inform to each and every clinicians or each and every users about the change in uncertainty. It is only when it is requested. Even the standard says measurement uncertainty should be available in the laboratory, and it should be available whenever the users request. So whenever there is any change in measurement uncertainty, obviously we have to do a root cause analysis. If it is increasing, if it is decreasing, it's well and good. If it is the uncertainty is increasing, obviously we have to see there may be some wear and tear of the equipment, maybe the operator has changed, reagent lot has changed, QC itself is not stable. So these are some of the sources where uncertainty may increase. So if it increases, then obviously we have to find out the actual cause and we have to correct it. If it is decreasing, it is well and good. And we need not have to inform all the changes or any changes in uncertainties to our users. It is only when the user requests, we need to inform them and we have to explain them about those uncertainties in our measurement.
Actually, you are saying about the qualitative, mostly in infectious serology.
Yeah.
So we say reactive or non-reactive, and say you can calculate from intermediate data. So when somebody report that this is reactive or non-reactive, how the result can be interpreted with the MU for that particular qualitative test?
See, when we generate reports of ID serology, basically when we label any result as a reactive or non-reactive on the basis of cutoff values. So for example, I will take a simple example. When I am reporting a HIV test positive, so there will be some cutoff. For example, it may be a 0.5. It may be a 0.5 or optical density, above which I am going to report it as a reactive, and below which I am going to report it as a non-reactive. So if I am calculating my measurement uncertainty using known positive and known negative samples, here we will take them as a control. So on the basis of them, I have to calculate how much uncertainties are there in those observations. So for example, if my cutoff value is 0.5 and my uncertainty is 0.1, and I have a sample whose OD I got is 0.4. Now, the maximum OD considering the uncertainty will be 0.5. So the test result may be reactive on the basis of uncertainties what I have calculated. So at these cutoff values, if a clinician has a strong suspicion, if a clinician has a very strong suspicion that this case may be a HIV positive, the patient is showing all the signs and symptoms of HIV positive, and still your report is, because on the basis of OD 0.4, I have simply told that this is a non-reactive. But then if the clinician has query, I am finding a patient who has all the signs and symptoms, and according to my clinical judgment, the patient is the patient is HIV positive. How can I tell that, or how I have released the report as negative? So I have my reasons. OD I have, for me, is 0.4, my uncertainty is 0.1, and my cutoff is 0.5. So yes, this patient can be on a borderline or can be a reactive patient. So that is how in cases of ID serology also, this will be very useful of measurement uncertainty when such cases comes, whenever it is at the cutoff value. I have already mentioned when it is frank positive, when your OD goes about 2, 2.5 or 3, at that place I may not have to use this measurement uncertainty, because already it is a confirmed positive case. But when the ODs are on the borderline or on the cutoff values, then these measurement uncertainties will be useful.
Actually, in this case, this is not a question, just to add on. So you are saying that we need not put it in our report, uncertainty. So I heard the former IFCC president, he was talking, then they started giving some 10 years back. Then his clinician, so far I was believing that when you give a glucose of 112, I was thinking that it was 112. Now you say it is not 112. So something like that. So they had to withdraw it from the report.
It is not mandatory to include. It is not mandatory. Rather, you should not include, because it will create a lot of confusions. Yeah. For calibration laboratories, if you see the calibration certificates of our pipettes or centrifuge, it is mentioned there what is the uncertainty, because the report is given by technical person and is used by the technical person, but it is not the same case with medical laboratories. The report is given by technical person, which is used by even by layman. So it will create a lot of confusion for them, and it may create some other problems or some other issues. So it should be available and should be made on request whenever it is requested by the users.